Hi, my name is Taylor Bukovic. I would like to welcome you to talk about early ambulation in postoperative patients. Early ambulation has several effects on the body following a surgical procedure. The specific population of focus for this presentation is post-abdominal and urologic surgical patients, as that is the most common population that we see on the 5300 unit. Now, ambulation can include anything from bed mobility, sitting up out of bed, hallway ambulation, and low-intensity exercise. A few things have already taken place prior to this presentation, such as the assessment, and a few interventions have already been set into place, but we will talk more about that. And also, some education will be provided during this presentation. The first step that has already taken place is assessment. Over the last few weeks, post-surgical charts have been audited, and the findings were that only 60% of our post-surgical patients had documented ambulation within 24 hours of surgery. This is a very low number when almost all of our surgery patients have orders for ambulation day one of surgery. Now, with that, there are a few interventions that are going to be set into place. One that already has been set into place is collaboration with physical therapy. They have measured the unit, given us the measurements, and we have placed signs at every nurse's station that display the distance. These signs will help us better document the actual amount of ambulation that is taking place with our patients. In order to get the total amount of ambulation, the distances on each sign have to be added in order to give the most accurate documented ambulation that we possibly can. You can also document by time. Documentation is done under the EPIC flow sheet. In the ADL section, there are options for sitting up in a chair, being up in the room, ambulating. Several other options are also available. There's also an other option where you can add free text in the comment section to specifically describe the type of activity your patient is doing. One activity should be selected in addition to documentation on either the minutes or the distance walked, whether just depending on what activity was taking place. Now, patient education is where we are really going to drive home the importance of ambulation. We have so many options at our disposal. But before we implement those, we need to make our patients aware of the expectations that we have for them after surgery, prior to them actually having the surgery. It should be explained to them that they are expected to be up ambulating on the first day of surgery. First day after surgery. This way they already have it planned out in their mind and they know what we expect of them. Another tool that we have at our disposal is Sonify. We're not real familiar with it, it just went live, but this gives you the option to assign videos to your patient from Epic that they can view on their TV, and it will also give them a little test at the end of the video in order to assess their comprehension of the material that they were given. We have videos available on ambulation and actually education on some of the complications when they don't ambulate. Another resource that we have is CRAMES. This is printable information that can be given to the patient about ambulation and other potential complications if your patient really isn't tech savvy. Now, another intervention is going to be staff education. The staff is going to be the face of change. We are the ones with patients daily, pushing them, educating them, and providing them with the care and knowledge that they need to really progress after surgery, which we will get into some of the complications and education provided here in a second. Now, why do we want our patients to ambulate? Well, it prevents complications. It is the best thing for them after surgery. The first complication that can be experienced after surgery is a deep vein thrombosis. Now, post-surgical venous thromboembolism occurs in 1% of patients. Of this 1%, one-third of the patients develop a pulmonary embolism, which means the clot that formed in the leg or what other deep vein this clot decided to develop in has broken off and gone to their lungs and can have severe effects on the body, even death. The risk of venous thromboembolism increases with the duration of surgery, and prevention is the most vital treatment. I don't really want to say treatment, but it's the best thing that we can do for deep vein thrombosis is to get our patients up and moving. Active ambulation significantly decreases the incidence of the venous thromboembolism. After institution of ambulation protocol in post-surgical patients, a decrease of deep vein thrombosis by 84% was seen in combination with other prophylaxis such as the SCDs, compression stockings, and pharmacologic prevention. But early ambulation was a big part of that. One of these interventions cannot do it on its own. Another complication that can be seen are pulmonary complications, including atelectasis, pneumonia, or an increased need for supplemental oxygen. Early ambulation has also been noticed to decrease these types of complications. Studies showed incidence of pulmonary complications increased with patients that had decreased mobilization. And a systemic review study showed patients with intervention of early ambulation had a 16% rate of respiratory complications, while a control group that did not have early ambulation protocol set in place showed 24% rate of respiratory complications. This is a big difference with a simple intervention of just walking. The last major complication that I want to talk to you about for patients that aren't mobilized and ambulated early postoperatively is decreased gastrointestinal mobility and also a paralytic ileus. Now, systemic review of 4 studies on early ambulation and abdominal surgeries noted difference in the time between surgery and first incidence of flatus between a mobilized group and a control group. The control group was noted to have an average of 71.86 hours before first flatus. This is the group that did not have ambulation protocol set into place. They were pretty much just allowed to lay in bed or ambulize at will. They were not really encouraged. Now, the intervention group that did have the ambulation protocol was noted that an average of 52 hours was seen before first flatus. Now, this is a almost 20-hour difference between the two. That is huge, especially when we consider the cost and length of stay that is affected by this. A paralytic ileus is one of the more common complications that can be experienced after surgery. Due to both direct and indirect costs, treatment of a paralytic ileus can cost $5,800. And a paralytic ileus also increases length of stay by an average of 6 days. If all abdominal and urologic surgeries receive early ambulation, costs can be significantly impacted. A hospital can save approximately $830,000 with the implementation of early ambulation protocols due to the simple fact that it helps to decrease length of stay and decreases the number of complications. There is no noted readmissions from intervention groups within a 30-day period. This means those patients that did get placed on this ambulation protocol did not have a readmission within the first 30 days of their surgery or within 30 days after their discharge from that surgery procedure. Now, evaluation will take place after we have implemented some of these things. In a couple weeks, I'm going to go back through these charts and really see where the documentation is. Documentation is the only thing that we have to go off of to see how many patients are being ambulated, and that's also what the physicians are looking at to see how their patients are progressing. So really focus on the documentation of ambulation, whether it be in a chair, in the hallway, or just walking around the room to and from the bathroom, and also using those distance cards posted at each nurse's station to help you document accurately. These things I can't stress enough. This is how we are going to tell our progress, and these are how the physicians are really telling the progress of their patients. And the physicians are the ones also pushing and promoting our patients to be mobilized. They're the ones coming down on us for this. So I can't stress enough the importance of the documentation. Now, does anybody have any questions about how to document, where to document, or further why we're choosing to ambulate our patients at such an early rate? Well, if there's no questions, I thank you guys for your time, and I have a more detailed presentation that I will print out, and it pretty much has everything that we have gone over, so feel free to take one if you ever need a reminder. Thank you.